Good morning. My name is Lieutenant Commander Cuevas out of Naval Hospital Jacksonville, and I'll be talking about neuroaxial anesthesia for the obstetric patient. Regional anesthesia techniques such as epidural and spinals are the most popular methods of analgesia in the parturient population. Not only are these techniques beneficial in providing pain relief, they allow for the laboring mother to remain awake and participate in the laboring process. These techniques can be used with opioids and local anesthetics alone, but the combination of the two allow for decreased dose requirements, causing fewer maternal side effects as well as little to no neonatal depression. Pain during labor can be felt in different locations depending on the stage of labor the patient is in. Stage 1, as seen in picture A, shows distribution of pain at the level of T10 to L1. Labor continues and the baby descends. Pain location changes. Picture B shows the transition from stage 1 to early stage 2. To picture C, the pain during vaginal delivery with distribution extending all the way to S4. The distribution of pain becomes important when dosing epidurals, as it may be seen that the patient is comfortable one moment and suddenly uncomfortable the next. This may be an indication that the baby is descending and volume is required to reach the increasing nerve roots. Though regional anesthesia is one of the most commonly used methods for analgesia, there are contraindications. Absolute contraindications include patient refusal, infection over the injection site, coagulopathy, marked hypovolemia, and true allergies to local anesthetics. Though not listed in the textbooks, during my OB out rotation, we opted to do a general anesthesia C-section on a patient with a white blood cell count greater than 31,000. The patient was educated on the risk of tracking any infection from the bloodstream into the epidural or intrathecal space. Relative contraindications include the patient's inability to cooperate and the use of unfractionated heparin or low molecular weight heparin. Regional anesthesia should generally be avoided 6 to 8 hours after subcutaneous dose of heparin or 12 to 24 hours after low molecular weight heparin administration, and these recommendations can be found in your ASRA guidelines. With the exception to Demerol, opioid-only regional technique does not produce motor block or sympathectomy, which may be beneficial to high-risk parturients such as those with significant cardiovascular disease, for example, severe aortic stenosis. Though this technique has its place in OB anesthesia, it does come with a disadvantage due to the higher doses required, causing increased side effects, most notably respiratory depression, but also including pruritus, nausea, vomiting, and sedation. The use of opioids alone also takes away the perineal relaxation qualities that local anesthetics provide. Spinal morphine doses of 0.1 to 0.5 milligrams may have benefit for the first stage of labor. However, the onset may take up to 60 minutes. It has also been reported that morphine alone may not provide sufficient analgesia for many patients. This is why a mixture of morphine and fentanyl or morphine and sufentanil are used, resulting in a more rapid onset of action. Epidural morphine requires a fairly large doses, oftentimes greater than 7.5 milligrams, to provide satisfactory labor analgesia. However, it is not recommended to exceed 5 milligrams due to the increased risk of delayed respiratory depression, and the analgesia effects are only good in the first stages of labor. Though the texts state this, it is contradictory to what I have seen in my out rotation, where providers routinely administer epidural morphine status post the delivery of a baby during C-section. Fentanyl and sufentanil produce rapid analgesia with few side effects and short duration of action. A single dose of epidural opioids have not been linked to neonatal depression. However, caution should be used with repeated doses. Combination of low doses of morphine and fentanyl or sufentanil result in a fast onset and prolonged analgesia with fewer side effects. Epidural and spinal anesthesia more commonly use local anesthetics, either alone or with the addition of opioids. When used in combination, there is a synergy between opioid and local anesthetics acting on multiple sites of action to include opioid receptors and neuronal axons, also allowing for very low concentrations of each medication required, reducing the side effects such as hypotension and drug toxicity. The use of continuous lumbar epidural is the most versatile and commonly used technique during labor, allowing the provider to add additional medication if necessary as labor progresses. When choosing a local anesthetic solution, the concentration of the local anesthetic must be considered. If opioids are admitted, higher concentrations are required, potentially leading to a more profound block, affecting the parturient's ability to participate or push. Individual safety profiles of each medication are also considered, leading many providers to use ropivacaine due to its decreased potential in cardiac toxicity. When using local anesthetics alone, higher concentrations such as ropivacaine 0.2% or ropivacaine 0.25% are required to provide equal analgesia as when using combined methods. When adding opioids, you significantly reduce the local anesthetic requirements to 0.0625 to 0.125%. Many providers use epinephrine in the test dose solution only and omit it from the continuous infusion because of the concern that it may slow the progress of labor and directly affect the fetus. Despite these concerns, it has not been proven that the addition of dilute concentrations of epinephrine have an effect on neonatal evaluation. Before you consider placing a spinal or an epidural, the provider must ensure that the appropriate emergency equipment is available, such as a positive pressure device for ventilation, oxygen, suction, laryngoscope and blades, endotracheal tube, oral nasal airways, intravenous fluids, epinephrine, ephedrine, atropine, propofol, and succinylcholine. Pulse oximetry and capnography should be readily available. Lumbar epidurals can be placed early in labor after the patient has been evaluated by an obstetrician. More dilute mixtures of local anesthetic and opioids, as discussed in previous slides, are utilized due to the concerns that their use may require oxytocin augmentation, operative delivery, or C-section, though these concerns are unsubstantiated. It is to the patient and the provider's advantage to place the epidural earlier when the patient is more comfortable and able to position easier. Positioning is tremendously important to help identify appropriate landmarks in midline. The sitting position makes it easier to identify midline and the spine in obese patients. It also aids in the spread of local anesthetics if administered for the second stage of labor to reach the sacral nerve roots. Every student hears the same thing when they approach their first parturient for an epidural. Positioning is key. With that being said, there are many factors that make positioning the lower lumbar region and pushing it out difficult. All spinal curvatures naturally increase, and included is the exaggerated lumbar lordosis. The added weight of the enlarged belly and breast also make it difficult to drop the shoulders and curve over the belly. Finally, the anterior tilt of the pelvis further complicates the positioning. Before committing to any needle placement or even donning sterile gloves, the patient should be in the most optimal position possible. Finding the epidural space may be difficult in some parturients due to the positive pressure caused in the space with the changes in physiology and anatomy during pregnancy. Unintentional dural puncture or wet tap can occur even with an experienced provider with the incidence of 0.25 to 9%. Most providers advance the catheter with their left hand, bracing it against the patient's back while providing continuous or intermediate pressure with a glass syringe filled with saline. An alternative method to advance is to use the wings of the needle with both hands advancing a few millimeters at a time. Changes in resistance is noted by continuous or intermittent pressure of an air-filled syringe until there is a loss of resistance. If an air-filled syringe is utilized, it must be ensured that less than 2 cc's is administered to avoid patchy or unilateral analgesia and headaches. The average depth of loss of resistance is felt at 5 centimeters from the skin, but that is very patient-specific, so make sure that you are cautious with patients who are slim. When passing the spinal or epidural needle, 3 distinct sets of ligaments are engaged. Just below the subcutaneous tissue and midline to the spine is the supraspinous ligament that attaches between the tips of the spinous process. As the needle advances, it can be noted to become more anchored into the spine, likely engaging the infraspinous ligament. Finally, your needle will engage in the ligamentum flavum or the barrier just before the epidural space. The ligamentum flavium is thickest in the midline, averaging 3 to 5 millimeters. Also, midline proves to be the greatest distance from the meninges, averaging 4 to 6 millimeters, decreasing the likelihood of inadvertent dural puncture. This picture illustrates proper sitting position and placement of either a spinal or epidural needle. The optimal space to place the needles is between L3 and L4 or L4 and L5. Please note that a very small space for the epidural needle must occupy, as well as to allow for the placement of a catheter. Depending on the hospital and the supplies available, there are many types of catheters that can be utilized in your practice. Picture D shows a multi-hold catheter that has increased in popularity due to its decreased incidence of unilateral block and false negative aspiration when assessing intravascular or interthecal placement. The multi-hold catheter should be advanced 4 to 6 centimeters into the epidural space to obtain adequate sensory level, as well as decreased incidence of migration of the catheter out of the space. Picture C illustrates a single-hold catheter and differs in placement depth to less than 5 centimeters to reduce the incidence of unilateral blocks. The decreased depth, however, favors dislodgement, especially those who may be obese. Finally, picture E illustrates a wire-reinforced catheter that reduces the incidence of accidental intravascular insertion and resistance to kinking. After the epidural space is identified, a test dose of local anesthetics of 1 in 200,000 epinephrine, usually lidocaine 1.5%, is injected either through the needle or the catheter. This injection should happen in between contractions as not to misidentify increases in heart rate from contraction versus the intravascular epinephrine injection. No bolus should be administered until after 5 minutes to rule out the placement of interthecal space or intravascularly. Increased heart rate can be seen within 30 to 60 seconds of injection, showing 20 to 30 beat increase. Some providers inject local anesthetic through the needle, assisting in the placement of the catheter. However, injecting through the catheter ensures properly functioning line. After placement of the catheter, an initial bolus that the patient can be placed in a continuous infusion alone or a patient-controlled epidural anesthesia, or PCEA. It has been shown that the use of PCEA decreases the total drug requirements and increases patient satisfaction. The volume utilized is based on a segment spread, usually 1 to 2 milliliters per segment. Bolus doses should be administered in 5 ml increments, assessing the level of spread and how the patient's blood pressure responds to the sympathectomy. Combined spinal epidural allows the ability to provide rapid pain relief with spinal injection of opioids and local anesthetics, followed by the placement of an epidural catheter for further pain relief. It is reported that the use of combined spinal epidurals increases the patient's satisfaction and decreases the incidence of a post-dural puncture headache. This picture illustrates the placement of a CSE. After feeling a loss of resistance from a spinal CSE TUI needle, the spinal needle is advanced through the TUI into the interthecal space where a pop is felt and positive CSF is aspirated. A dose of local anesthetic and/or opioids is administered and a spinal needle is removed. The epidural catheter is then advanced into the epidural space and activated as directed in previous slides. It must be noted that using local anesthetics in a spinal dose, the test dose is only effective in assessing the inadvertent intravascular injection. Spinal anesthesia can be used directly prior to vaginal delivery or as a method for C-section. The use of pental point needles decreases the incidence of post-dural puncture headaches. Hyperbaric solutions are utilized to facilitate appropriate spread. If the spinal is used for vaginal delivery, the patient is kept sitting position for 3 minutes to allow saddle block to set up. If T10 or higher is required for coverage, larger doses of local anesthetics is injected. The height of the spinal block is determined by the cephalad spread within the CSF. There are many factors that are suggested to affect the height or the spread of the block, though most are considered clinically insignificant. The factors that do have significant effect are veracity and the relative position of the patient. Though neuroaxial anesthesia is relatively safe, there are a number of factors associated with this method of anesthesia. Listed on the slide are a few of the possible complications. I will discuss intravascular injection, intrathecal injection, hypotension, and post-dural puncture headache in more detail. The incidence of intravascular injection is about 5 to 15%. It is important to recognize unintentional injections early. This can be facilitated by small repeated doses to prevent more serious side effects. Intravascular injections of toxic levels of lidocaine and chlorprocaine present with seizure activity. The activity can usually be stopped with a bolus of propofol of 20 to 50 milligrams. It is crucial to maintain a patent airway as well as oxygen delivery. Escalations to intubation are rarely necessary. If bupivacaine is injected into the bloodstream, rapid and profound cardiac collapse is noted and cardiac resuscitation is necessary. Immediate infusion of 20% intralipid has been proven to reverse the local anesthetic-induced toxicity. Finally, amiodarone is the antiarrhythmic of choice to treat local anesthetic-induced arrhythmias. Injection into the intrathecal space can cause rapid signs of a high spinal. Even if recognized immediately, aspirating CSF does not successfully decrease the symptoms. The patient should be immediately placed in the supine position with left lateral displacement. Elevating the head should be avoided as it increases the adverse cerebral effects of hypotension. Hypotension should be treated with phenylephrine and IV fluids, and intubation and ventilation should be initiated if spinal dose is high enough to cause diaphragmatic paralysis. Hypotension is a common side effect of neuroaxial anesthesia and is defined by the greater than 20% decrease from baseline or systolic blood pressure of less than 100. Hypotension is caused by a decrease in sympathetic tone and is accentuated by the aortocaval compression and/or upright or semi-upright position. Hypotension should be treated aggressively with ephedrine, phenylephrine, fluid boluses, as well as supplemental oxygen and left uterine displacement. Also, the practitioner should have a low threshold for treating hypotension, as nausea and vomiting is often the first sign of it. Post-dural puncture headache oftentimes follows an unintentional dural puncture. The headache is caused by a sudden decrease in intracranial pressure followed by compensatory cerebral vasodilation. The parturient patient may have a headache that mimics post-dural puncture headache after the use of a large bolus of air is injected into the epidural space. Treatment is conservative for mild to moderate pain with bed rest, hydration, oral analgesia, and caffeine sodium benzoate. If the headache is severe, it can be treated with 10 to 20 mL of a blood patch. As discussed in previous slides, the use of saline or air for loss of resistance are both acceptable options when placing an epidural. I was curious if there was any literature that would suggest the benefit of one method over the other, because clinically it's very provider specific. Much of the literature I found suggested no significant difference in the success of placement of the epidural, but found that each method requires a slightly different technique, which could lead one to believe that one is more superior than the other if they're not familiar with both. I did, however, find some interesting findings that might lead a provider to choose one method over the other. In a case report by Marcel Verakataran from the Timisoara Medical Journal, a discussion of the use of air for loss of resistance is addressed after a 34-year-old parturient experienced a headache after accidental injection of 5 mL of air in the intrathecal space. A CT showed air bubbles in the space and a headache that was persistent, becoming progressively positionally dependent. A blood patch was performed and partial alleviation of symptoms was noted, but the patient continued to have a persistent headache with now visual changes and lightheadedness. The patient stayed in the hospital for 8 days with 80% improvement on discharge and total resolution the following week. Pneumocephalus was likely the cause of the headache and is often difficult to differentiate between post-dural puncture headache. Because of this case, the author researched other potential complications. It is suggested that the use of air technique may increase the incidence of wet taps, as seen in multiple studies, but the evidence level is low. It is suggested that the increased incidence in dural puncture may be due to the unfamiliarity of the different techniques and equipment, not necessarily the technique itself. There is a benefit of using air. One most identified was placing a CSE. When using air, there is less question of the fluid returning from the spinal needle being CSF. It is suggested that the use of less than 3 mL of air and becoming familiar with the technique are required to be successful. Finally, if the epidural space needs to be re-entered, the use of saline is suggested. Another article by Hessen et al. Did a systematic review of the literature to see the best method to reduce the incidence of post-dural puncture headache and found reduction in the risk of accidental dural puncture with the use of liquid for loss of resistance, though the results were only found in low-quality studies. With that being said, the authors could not make a recommendation based on the low level of evidence. Thank you all for listening. If you have any questions, feel free to give me an email, and I look forward to the discussion board. Here are my references. Have a great day.